I want to introduce the chair for this last panel today. This is a panel that is a collaboration with or hosted by BICEPS, the Bergen Center on Ethics and Priority Setting, which is part of the Center for International Health, which is part of the Department of Public Health and Globe. Oh, so Omar will correct me later, and I should know. But anyway, so and Camila Gianella is a very dear colleague for many, many years from LawTransform, from the Christian Michelsen Institute, from the University of Bergen, now based in Peru and working at the Catholic University, the PUC, in Lima. And Camila is a psychologist by training, public health, very versatile, knows a lot about a lot of things, and especially about health systems and health system, been thinking about health system reform, and how health systems sit in societies and the contextual nature of health systems. So I'm super, super happy that you're chairing this panel.
Thank you, Siri, and thank you all that survived the whole day, even the poor quality of the air in the room. And really welcome to this session. I am really happy to be able to be here with three colleagues. I think that Alicia Yami, she's not coming because of the COVID reason, so I think this is also important to say that the pandemic is not over, so it's good to speak about that. I think that here, some people were thinking the pandemic was over 2 years ago, but no, it's still here. Also, I have here Pedro Villarreal. That he received a PhD in law from the National Autonomous University of Mexico. And he's currently a senior research fellow at the Max Planck Institute for Comparative Public Law and International Law. He conducts research on international and comparative law and human rights, and he has a lot of expertise on researching the role of the World Health Organization. I'm really glad that you're here with us, Pedro. And then we have Omar Muan Lim. Omar, that he's, I think a lot of people come because of him. So, Omar is a former director of NSC at the Ministry of Health in Zanzibar. Currently, he's a PhD candidate at the University of Bergen, and he's part of BICEP, where he's the lead of the Zanzibar project. Really nice to have you here, Omar. I think we met before the last year in a panel like through Zoom, so it's really nice to finally meet in person. And our third panelist that I think I hope she will able to join is Alicia Yami. She's currently a lecturer on law and the senior fellow of global health and rights at the Pedro Center for Health Law Policy, Biotechnology and Bioethics at the Harvard Law School. And she's also part of the LawTransform. And yeah, Ali is here. Hi, Alicia. Nice to see you. So this is a panel on decolonizing the global health governance. And I think it's really important to have this panel now to speak about what means global health governance. I want to start with an example that things that we need to start to think like, I am from Peru. I don't know how much you know about how bad has been the impact of COVID in Peru, but it's like the whole Bergen disappeared. That is the amount of people that died in Peru for COVID. But we were not the ones that decide the decisions at the World Health Organization level. We were not also the first on getting the vaccines, and we have not been the people in charge of deciding how the vaccines were going to be distributed. So all these things on global health, I think there are things to discuss. So I am very glad to have you here to start this discussion. And we are going to start with a brief introduction from Ali to the panel. Ali, the floor is yours.
Thank you, Camila. Well, it's really a delight to be on the panel, and I wish I were there sitting between Pedro and Camila right now. I was able to see Omar in June, I think. And I still have not met Pedro in person, and Camila, of course, I've known for many years, but it's really just a delight to be able to participate. So I thought in communications with Camila, I thought the most useful thing might just be to set out some concepts and frameworks for the discussion. And I really want to focus on this idea of decolonization, but it's worth just talking for a minute about global health governance and what that actually means, instead of assuming we're all talking about the same thing. So some people use the word global health governance to refer to the WHO, of course, and the other agencies within the UN system, UNAIDS, UNICEF, UNFPA, that focus specifically on health mandates. But there is another closely related term called governance for health, which expands out that understanding to the WTO, the IMF, the World Bank, the regional development banks, for example. And I will largely be talking about that global governance for health, because I don't think it makes sense to narrowly isolate the specific health agencies. So those are kind of the formal institutions, but then there is a lot of governance in global health that is done through informal and background norms. So there are many, many funds in global health, development agendas, set governance priorities. There are research institutions like the IHME that play quite a large role in defining what indicators are used and how they measure progress in the world. There are scholarly groups. Pedro and I both belong to something called the Global Health Law Consortium that, somewhat pretentiously sets out to define the field of global health law. There are private actors, right? And here I would signal out the really disproportionate role of the Gates Foundation, which plays a role in every way, in defining priorities, setting indicators, doing evaluation, constructing institutions, and I'll come back to that. And there are also background norms in institutions, right? Who is placed at the highest levels of these institutions? Recently, there have been a few Africans chosen at the WHO and the WTO, most notably, and UNAIDS, Winnie, but there is a question about how decision-making structures within these institutions function as well. And those comments kind of give an appropriate idea of how messy global governance for health is. I think if I had to tease out a through line, it would be one of increasing concentration of private power. So these institutions were set up in the post-war world. They were always anti-democratic and colonialist. I think the remarks by some of my eminent colleagues about how this pandemic has shaken the foundations of global health governance is absolutely not based on reality. I think that's revealed the colonialist foundations of global health governance. But there's a through line of increasing influence of private power through the Gates Foundation that had become the second largest donor to the WHO before the pandemic, and is on these different boards, all of these different boards, basically, of private power, of the framework for non-state actor engagement in the UN Global Compact. So there's a colonialism, I think, that is inextricably linked to a trend toward neoliberalism, right? And that leads me to the second set of comments, and I'm not going to go on very, very long, Camila, don't worry. That I see the decolonization thing, and I completely agree with comments by Shea Abdimullah and others who have said decolonization means different things in different contexts to different people. But I'm going to point out two dimensions here. One is a political economy dimension, and that has very much to do with this kind of through narrative of increasing private power to define agendas, to define spending, to define the terms of spending, et cetera. And I think the TRIPS waiver is a very good example of that. A handful of G7 countries refused to go along with the TRIPS waiver during the pandemic that was originally proposed by South Africa and India, and really locked up the WTO discussions, and the kind of thing that came out at the very end of is not an actual meaningful waiver. So I think that it shows, but the G7 was not acting just as purely nationalistic. It was acting also because in capitulation to these pharmaceutical monopolies that wield an extraordinary degree of influence over our domestic political processes. But the second dimension is more epistemic. It's, again, about a definition. What is a public health emergency? Is malaria a public health emergency? Or is it only something that affects the North and the industrialized high-income countries? What indicators are we going to use to measure progress in global health? Those are largely selected but now increasingly by institutions like IHME to be comparative and objective, and also to be able to be calculated through algorithms, which allows for governance at a distance. So, you know, what is the knowledge that we value in global health? Is it the knowledge like in a GPS? Or is it the knowledge that you know from knowing the people who live in certain places, knowing their traditions, including the how their climates are doing, whether they're eating, whether certain facilities are functioning properly or not? That knowledge is not valued in global health. All right, so I will conclude because I'm eager to hear what other people have to say. What is the response, right? Well, I think there are a few things. One is that we can start creating evidence from the ground up. And I'm proud to say that Partners in Health, where I am a senior advisor, does this all the time. The All Babies Count initiative is based on work at our local care delivery sites. And then it generates evidence up and is scaled. The second thing we can do is change the political economy, and that's another initiative that I'm very deeply involved in now that I've shared with Siri on global public investment to incentivize, instead of incentivizing private initiatives and insurance schemes, incentivizing shared pooling for global public goods or common goods that transcend borders. This could be regional as well, digitalization, electrification, to mitigate climate change, and obviously pandemic preparedness and response. And the third thing I think is just a caution. I'm also a human rights lawyer, and there is a prevalent narrative about achieving human rights through global governance, human rights in health through global governance. And I think we should be very wary of that narrative and suggestion. And I'm happy to describe more of that. Okay, back to you, Camila. Thank you very much.
Thank you, Alicia. Thank you for this intervention. And so I would like to now to give the word to Pedro.
Thanks so much, Camila. And first of all, thanks, heartfelt thanks to City Glopen and Lara Barbosa and everybody at LawTransform for allowing me to be here and share my thoughts with you And it's always, of course, a delight to follow Alicia's own comments. That makes my life much easier because she sets the scene so extraordinarily that now I simply have to piggyback on her comments and build upon them with my own perspective. And particularly, she was referring to multiple issues within global health governance. I'll focus on one of them, but addressing different two dimensions of it. Particularly the role of the World Health Organization, right? An organization which, at least intuitively, would be at the center of an event like the COVID-19 pandemic. In some ways, it was, right? It gained media attention like it never did before, I would dare say. And at the same time, I fully agree with Alicia's assessment that the COVID-19 pandemic ultimately exposed already existing shortcomings in the framework of global health governance, including the legal framework, of course. And in the WHO, it revealed at least two major shortcomings, and I will address them briefly. So first of all, what Alicia was referring to, and I guess it's the broader theme of I think Camila made a very clear example of, priority setting made by a few actors that are, at the top and in a very asymmetrical global setting. And of course, this inevitably results in very broad and very, let's say, general frameworks that ultimately don't manage to really capture on the ground realities and tailor responses to what's needed really on the ground. And there are reasons for that. It's not just the fact that, okay, these are institutions that are operating at a certain level and globally in Geneva and with a particular high diplomacy. That's not the only reason. Of course, there's also another challenge, namely how to really be aware of what is needed on the ground. I mean, this is beyond the knowledge of any one single institution, particularly considering how an event like the COVID-19 pandemic and all of society event has so many dimensions to it that it's beyond really the mandate of one single organization, particularly the WHO, to really address all of these, all of the challenges that emerge, not just from the public health side of it, but we see how the pandemic has affected nearly all the aspects of our lives. Alicia, for example, was mentioning intellectual property rights, right? And how we have in this market, in this global market, we have designed access to medicines under a profit-based logic mostly. And this, of course, means that pharmaceutical companies, among other actors, will cater to the interests of their own shareholders. This again, which at its face might seem like an obvious global health problem, this is beyond the World Health Organization. I mean, to mention one example, right? This involves the World Trade Organization and intellectual property rules. And so this is a challenge in terms of how really to set priorities globally when no single organization, in my view at least, has the mandate or the capacity to really address all of the aspects that are involved in an all of society pandemic like COVID-19. But this is not, of course, to justify the WHO's limited or constrained action in the face of pandemics. It's just in a way of trying to visualize the challenges that lie ahead, particularly as currently we are witnessing the negotiations at the WHO on either a new convention on pandemic preparedness and response or reforming existing rules, international law rules, namely the international health regulations, which were supposed to address problems like the COVID-19 pandemic, but as we saw, they fell quite short of what they had set out to do. So in these processes of negotiating and reforming existing norms, we do see inevitably how these challenges come up, and currently they're being addressed at the WHO, but their question remains: to what extent does the WHO suffice, quote unquote? To what extent really can we solve all of these problems solely through the WHO, which is what I've been focusing on. I have my own view that some of these issues will not be solved through the WHO, they cannot be solved by design. And then, we heard in earlier panels today how design ultimately defines many of the outcomes we see. This includes, of course, how robust can we expect a pandemic preparedness and response framework to be. So this is one aspect, right? The inherent limitations of the mandate of an organization like WHO, not to mention financial constraints, etc. But I will address another dimension that also relates to what Alicia just said, and that is the epistemic dimension, and the way in which global health governance, at least until recently, had been devised and had been framed by the WHO itself. And I'm, of course, oversimplifying. This is a big topic in itself. But what we saw, and this relates to Alicia's comment on how these global health governance indicators and interventions are often not really reflecting what was needed on the ground, and many of the aspects that are, let's say, go beyond a strictly speaking biomedical approach towards global health issues. So Alicia did indeed refer to these problems, and I will go a bit further in the case of the WHO and say, historically, and since its creation and throughout the decades, the WHO was composed of mostly technical experts and personnel with a strong biomedical background, meaning usually they had medical degrees. The current WHO Director General is the first one not to be a medical doctor, right, in its existence. And this did reflect a certain way of addressing problems, and to the extent that other perspectives, like those of social sciences and correlated disciplines, where we see that there needs to be some sort of awareness of the scale of the problems, was simply absent. And I think this is an indicator of an example of how there needs to be an expansion of what global health governance means. And this goes as well through the epistemic understanding of this biomedical focused perspective towards global health governance. It's not just about technical interventions, it's also about socioeconomic challenges that underlie healthcare systems. And this is where the pandemic did reveal the shortcomings, and where we are witnessing some sort of reaction by WHO personnel, where they do take some steps in order to include more perspectives. There is now an active open call. There are now active open calls for disciplines other than the biomedical sciences. So this does show some sort of responsiveness. To what extent will this responsiveness be enough? Well, we can, of course, as usual, be skeptical, but at least it does show that in the past that this did not happen, right? In the past, it was really mostly through these devising the best biomedical interventions, whether vaccination campaigns and so on, which achieves many things, but at least the very, really the magnitude of this pandemic has revealed that this simply is not enough. And let us remember, of course, that not only do we have the COVID-19 pandemic, but we are also currently witnessing a multi-country outbreak of monkeypox, a problem that had been neglected during decades, even though this is really not a novel disease. We knew this disease. It was simply, as Alicia mentioned, that that this had not become an emergency until it started affecting many other countries besides those where it previously was. So we do see how there needs to be some sort of, maybe reckoning is too strong of a word, but at least an increased awareness of the multidimensional aspects of these problems, because moreover, and I will conclude with this, there's currently an ambitious deadline for all of these reforms, all of the new rules that they want to devise. They want, at the political level, negotiations are geared towards coming up with new rules by 2024, which, considering how big the task is, seems over ambitious. Let's see what happens. But we can wonder whether this is enough in order to have meaningful discussions on how deep we need to really address the social determinants of health at the global level, which really is, in my view, the best remedy against future pandemics like COVID-19 and the monkeypox outbreak. Thank you so much. I'll leave it at that to continue the discussion.
Thank you, Pedro. And Omar, I have been listening Ali and Pedro and thinking from your experience, and we think on this governance for global health and these dimensions that Alicia and Pedro has been mentioned. In your experience, how this affect the job that you have at the that you have been doing in Zanzibar at the level of implementing policies, when you have also to follow, for example, this epistemic of the global health and these indicators that have been decided outside, but also influence on the policies that you in the countries we have to implement. So I would like to hear more about your thoughts and the challenges that this also represents on the job that health authorities have to do in their countries.
This one is working.
Yes.
Yeah, thank you very much. First of all, I'm very much honored to be part of this panel and share the little experience that I have. Being a public health practitioner, I'll talk a little bit about this global health governance, but I'll particularly focus on the decolonization. And this is what I've been prepared for. And this could have different perspective. Academician could look at decolonization from different perspective as practitioners. So we've been experiencing this from over the decades, decolonization. And mostly we've been focusing more on North-South decolonization. Usually we tend to forget about the decolonization that is within the countries. This is, I don't know the right time to call it, whether local decolonization or whatsoever we're going to call it, but it is there. And most of the time, these decolonizations, they are coming with good intentions. Maybe we need to avert some disease burden, we need to strengthen health system, and so many other things. But due to the designing and colonial structure of those many projects that are coming, they end up having not expected effect or long-lasting effect or outcome maybe as expected. I can give you some examples. For instance, in Zanzibar, we've been getting support to different programs like TB, HIV, malaria, neglected tropical diseases. And you could see that most of these projects were designed from the north, and they're brought in there, they're implemented. Once the implementation of the project ends, and then that's it. Of course, as a country, we do benefit from that, but what is left behind is very little than what is being taken by the institutions from the north. So we do benefit, but also we do lose a lot through this decolonization. Talking about, for instance, malaria, Zanzibar is one of the countries in the world which has documented the best practices in malaria. Now we are at the elimination stage of malaria. But then there were so many which was published as research or journals, but then you see very few authorship from the locals. So that's a problem. And this is something that we need to see how best we can address it. But the other thing is that we have so many partners coming in to support. I was an external aid coordinator at the Ministry of Health in 2011 until 2012. And my very first assignment that I took during that time was to map out the partners that we have in the health system and what specific areas are they supporting? And what is the contribution each of them is giving? So for instance, looking at the reproductive and child health program area, we had like 7 different partners supporting that particular area. But then the maternal mortality ratio was above 300 per 100,000 live births. These partners were not talking to each other. The transparency was not there. At the end of the day, the project ends, we evaluate the project, we did well, and then that's it. If there's a continuation of the project, we can continue. If there's no continuation, then we finish the business. The bad thing about this, sometimes, we lack a lot of expertise in implementing the project. So even the experts are coming from the north. They help us implementing the project. And then, so this is a big challenge. But then we have people like me, for instance, I have network with different partners. I write the proposal myself, and I design the implementation plan and everything, and I just go to the field and implement. I don't engage any stakeholders. I remember in early 2010s, we had support from the African Development Bank, ADB, and it was about improving sanitation and hygiene. So the managers of the project, they just sit on the table. They thought of maybe constructing latrines in the rural areas, and they did it. They chose the sites themselves without involving the local communities. And then they went and they built the toilets. So after some times, when they want to evaluate whether the latrines are being used or not, they only saw goats, cattle, sheep lying in the latrines. So at that time, they had to sit down with the people and talk to them why they're not using the latrines, and instead they're used for keeping their livestock. And they said, no, you did not engage us in selecting the sites, because this is against the culture. Building the latrine near the market, and then you expect a woman to go to the latrine, to the toilet where men see them. So this is a local colonialism that is still there, but we tend to overlook. We don't see it very much. So I think there's a lot that we need to see to address when it comes to these decolonization issues. We know that we are lacking resources, we are lacking capacities, and maybe the connection, we are bad in communication sometimes. But if we can strengthen this, then we'll get there. At least in the last 10 years, we've seen some projects are coming to Zanzibar, for instance, and maybe in those projects they have these components of maybe capacity building, where you train people on masters or PhDs. At least they've started to help a lot. We had this collaboration with the University of Copenhagen, the project that I was leading called Building Stronger Universities. And with this project, at least we've managed to establish the bachelor courses on environmental health sciences, and it's up and running now. So at least, so if we manage to collaborate with universities maybe and strengthen the capacity of our people, probably we can reach the goal. But otherwise, we'll be still talking about decolonization, and then at the end of the day, we will not walk the talk. Although we have challenge, because in our settings, once you are trained as a PhD, and if you are found that competent, then you are being taken by the politician giving administrative positions or political positions. But that's an in-house issue to sort out. So briefly, I could say that.
Thank you, Mar. And listening to Omar, I also was thinking with you and Ali and Pedro that you has been working on these issues of global health governance, but at this different like international level, how you don't make that this is also reflecting the same powers that you want to, combat in a way. So how you not replicate the same power imbalances when you are like discussing the things of the political economy and the problems of the global health governance, but at this level, like a high level, and or with the heads of the ministers and health authorities from the countries, but there are these elites, no? And how we prevent to miss this also, to prevent to miss all these power imbalances also at the level of the countries, or how we are replicating the same power imbalances when doing this. So I don't know if you have some reflections on this, because I can say, I am a nice person and I would like to improve the health in Peru, but I am super white and my from Lima, from the private university. So what I understand from health is different. Even my experience from the health system are absolutely different than from indigenous communities. So how to involve them more on these processes is something that I would like to listen from you. Ali, if you want to start.
I'm happy to start, but I'm also happy to defer to Pedro and Omar.
Okay. Pedro, Omar. Well,
All right, I'll take it up. And yeah, thanks for the question. So how to, well, I guess the first step is indeed to identify those power imbalances properly, because what happens, at least what I see at the international level with international law and negotiations is, it usually starts from the basis of rules that are supposed to apply to all, equally, unless of course there are some clauses, but but this is already the first challenge. So how to come up with abstract rules in the case of law, abstract rules that can really devise meaningful obligations for states, taking into account the fact that not everybody's in the same position, and this also relates to how international organizations and either the WHO or any other like the WTO, how they themselves can well, maybe I shouldn't be apologetic. They simply replicate these power imbalances further, because obviously, some member states have much more weight than others in the decision making. Just to mention one, let's say, provocative example, let us remember, of course, that this, according to the latest research that tilts towards the origins of the COVID-19 pandemics being in a wet market in China, right? And of course, the way in which an international organization like the WHO engages with a country like China will be very different than the way in which it engages with any other countries which maybe do not have the same capacities and the same leverage as China, let's say the rising hegemon, right? But at least this should be a first step in acknowledging that there is indeed a disparity, obviously in terms of capacities, but also in the way in which international institutions, the WHO, the WTO, the IMF, the World Bank, you name it, the way in which they engage with different countries already, reflects and to a certain extent reproduces these power imbalances. And I do believe the other problem you referred to is even, well, at least from an international law perspective, the challenge with addressing also imbalances, and the ones that Omar was referring to within the country, is that usually we take states in an aggregated fashion, right? It's the state of either of South Africa or the state of China, the state of Mexico, the state of Tanzania. So these are states that are not disaggregated at the international level. And this is already, of course, this does not reflect really the multiple layers within countries that really do show us what type of imbalances we need to deal with if we want really to foster the ultimate outcome of improving access to healthcare, improving the quality of life, the physical and mental well-being, as the Constitution of the WHO affirms that if we really do want to achieve those outcomes, I think there are multiple layers that we still haven't been able to really address meaningfully through international rules, at least. That's from my side.
Yeah, maybe I should try to mention or to think of the best ways maybe that we can address these issues. We know that there's a, I don't know if I say huge or just a gap. I mean, the knowledge and technology gaps between the northern world and the southern world, especially in our low-income settings. So I think we need to find the best way to address this. And from this end, you have skills, you have resources. But from our end, we have solutions to different problems. So, and we know how to navigate, I mean, to get there. So it's about seeing how best we can work together and address this. But also engagement of the locals. And this one is very important. For instance, currently we've been revising the essential healthcare package in Zanzibar. And this is the project that I've been working on since 2019. But I appreciated the advisors of the group, Ula and Shalona. They clearly told me that we don't give you fish, and we will not teach you how to fish, but we can teach you how to construct your own boat. Once you have a boat, then you can go fishing and you'll know how to fish. And that's what exactly happened. And I did it because we just used the local structures that we had in the country. We've managed to build the local capacities, and we did it. And during the process, we've seen this colonization coming in to interact, but then we've tried to stop it in many ways. For instance, there are interventions that are not related to Zanzibar, and maybe they are not applicable in Zanzibar. They were part of the package, but we say, no, this is not for Zanzibar, and then we cannot include this in our package. So it should work in that way. So I think seeing how best we can work together and implement these projects, this is very important. But again, we're seeing another problem. For instance, in these publications, okay, you could see maybe the researches were published in different journals, but we are lacking free access to those journals as institutions. For instance, Ministry of Health wants to access, a paper or journal related to HIV and AIDS. They have to pay it for it. And you could see that the research was done in Zanzibar. There were Zanzibaris who were used they were studied. You see, again, we don't have these sort of policy briefs, maybe at least to inform our decision makers of what has happened. Again, we need to see how best we can also do this. Researches, the papers should be translated in a very simple way. Even those people at the local communities can understand. Okay, one day I've been interviewed on this, and these are the results. So I think we need to work towards that way. Thank you.
Ali, I also want to say
Sure,
something.
I love that story from Omar, both the positive one about the fishing and also the really, really deeply entrenched problem of accessing the knowledge that Zanzibaris themselves are creating. So I want to talk a little bit about having navigated this question quite a bit. I should say from the outset that one of the great privileges of my life has been that I have been able to work within local groups. In Mexico, human rights groups. In Peru, as Camila knows, I worked in a Asociación Pro Derechos Humanos, APRODE, which changed it without displacing local staff, with other funding sources that allowed me not to displace other staff. So one that was useful because I was taking direction and incorporating the agenda of local people about what their priorities were. Similarly, I think it's important in, as time is, and that has been the choice I've made throughout my career, to work through local organizations and allow them to set the agenda of priorities. I think it's similarly, just as Omar was suggesting, important to return knowledge, and not just to the researchers of the Ministry of Health, but when we did research in Tanzania, we had very simple messages printed in Tinga Tinga form on kangas, and went back to every single village, every focus group we had done. That is, of course, time intensive, expensive, but I think it's the de minimis expectation that we can expect. I think in the many other spaces that we all inhabit, there are ways to gently but firmly continually reiterate that the way the discourse is framed, or the framework is understood, excludes a lot of people's gazes. I recall that since maybe about 2010, all meetings started being expert consultations. And at every single one, I would raise my hand and say, why is this an expert consultation? Like, what are the criteria for defining expertise? And I think that's a problem in global health that we should really all be aware of. It's similarly a problem in these academic scholarly groups, as including the one that Pedro and I are both in. How do we understand what, quote, expertise really is? And I think we should continually interrogate that, and not expect just adding on a few people from the global South is going to make us universal and representative, because that's not the way reality works. I think we can be also, selective about supporting the organizations that really do a very good job at countering this, like BCEPS. I'm very proud to be a member of BCEPS, and I think BCEPS does an amazing job at partnering with different local groups and producing evidence, and not just evidence, but capacity. I also think Partners in Health does the same thing. We don't call ourselves experts, we call it accompaniment. So we meet people in the different care delivery sites on the terms they are, and accompany them as they decide to make improvements. And in PIH, which is a very large international public health organization, we work in 12 countries. The Leadership Council is made up of people from those 12 countries, not a bunch of Americans. So I think that is helpful as well. And the third thing I think is funding, right? Is breaking down this completely obsolete notion of donors get to choose their politicized pet projects and set the indicators, which are ridiculous. I mean, a ridiculous array of indicators are imposed on so-called recipients or beneficiaries. I remember when I lived in Tanzania, and one health activist said, yeah, the donors come with their agendas and the government dances its jig. And that has to stop. And I think one small way and that can help is to re-incentivize development finance to focus more on common platforms, on public goods that often transcend borders. So I'll stop there.
Thank you, Alicia. So now I would like to take some questions, comments, so we can have like a discussion. So there is a micro there here, so we can line there and.
Hello, thank you to everyone. This is really exciting. I think I would simply like to learn more. Ali, you mentioned two things: the global funding, public goods global funding. I mean, I would like to know what kind of initiative that is and whether this is something that's actually taking some shape, or is it more at a conceptual level? But also the human rights, don't go there, that you seem to suggest that was a limited source. And I would also like to know, we've heard from you, because Omar has been very concrete in giving us, suggestions about how to improve what's not working. But what would you say, Pedro, in terms of the health organization, the World Health Organization? What is the agenda for reform that you think, besides adding disciplinary diversity, which I think is the one thing that you already advancing?
We take a group, so yes, Rachel.
Thank you all. Hi, Ali, on screen, and this was a great panel. Maybe it's an unanswerable question, but I would like to know what you think about whether the COVID pandemic has improved or made much worse the prospects for the kind of decolonization that you're talking about. It's a very broad question, but I'm thinking about some of the things you're talking about in terms of decolonizing knowledge and local knowledge, and some of the anthropological work that went on around, the Ebola outbreaks, right? And kind of what happened with COVID. Yeah, thanks.
Hi, Ali. And hi, everybody. So my question is perhaps one that's more specific and broad at the same time. And the thing that has really struck me, and Ali started with it, is this unbelievably unforgivable and exposing issue of this major global crisis that landed 2 years ago. And the governance machinery chose profit over lives. And part of that was obviously the WTO apparatus. And the countries that, what is astounding to me, having not previously worked on the WTO very closely, is that it wasn't as though if it had been put to a vote, there were more countries that would have voted for the WTO TRIPS waiver proposal than those blocking it. But because of the, how should one say it? I don't know. You have to call it a gentleman's agreement, and probably in that gendered term, it wasn't even put to a vote because effectively they rely on consensus positions. And the question I really have to ask is specifically, why did Norway line up on the wrong side of this equation? And if Norway did that, what hope is there? And it's not just, I'm not just trying to be provocative, although, I always do like that as well. But, I think we have to understand the motivations in order to try to deal with them. And I understand Switzerland, the UK, and Germany, because of the huge pharmaceutical company specific stakes, involved in the COVID drugs. But I'm at a loss about Norway. Thanks.
Thank you, Anna.
Yes, hello. So this was really interesting and triggered me a lot of questions. And I'm thinking about the idea decolonization is not a metaphor. And we're talking about practices here in Zanzibar, Omar and Ali in other places in Latin America. And I wanted to ask, because I think internationally it's another thing and difficult, I guess, but the pandemic also revealed the racism behind all the governance about vaccination, about confinement, about all that. So how do you approach scholarly, but also in the practice, the racial and the racism behind decolonization and this big word, right? That, thank you.
Thank you, Amita.
Thank you. This was a fantastic panel. Ali, it reminds me, the pandemic situation really brought to light the work that we did on the health rights book a decade ago, which started this work as well. And I was wondering about the role of India, because India, in the health rights book on the India chapter, India was one of the more promising stories on the right to health, because there had been litigation in India which had challenged intellectual property protections for drugs, because India is the largest manufacturer of generic drugs. So they had used the right to health successfully to challenge protection for drugs under intellectual property regimes. And of course, India manufactured its vaccine and supplied to many other countries. But I was wondering, to Jackie's point, like, why didn't India do more? Or, she's like, why didn't Norway do more? But why didn't India, South Africa, why couldn't they do more to push against this kind of protections in the TRIPS regimes? Also, just wanted to say, Omar, your description of how policy is made and implemented in a terrible way. I mean, it really resonated with the building of toilets in India and what the Bill and Melinda Gates Foundation, the way policy priorities are laid out. But I was also thinking that it's not just the international organizations, like the state was also, we had a very different implementation in different states, where states were more consultative with the people. The policy, the toilets were more accepted, with the communities were involved. So I was also thinking about, within the colonization structure, we seem to be colonized both by the corporations and this, but also the state within our setups, and also the colonization of knowledge and intellectual property protection. And therein, one hopeful thing I want to end with, which was again the courts in India, because India did have vaccines, but they didn't want to provide vaccines to everyone. Above, they only wanted to provide for free above a certain age, which is 60 years. And it was only through a litigation before the Supreme Court, where the court asked them to account why they were not providing for everyone, that actually, the vaccines were available for free to everyone. So that was one hopeful story. But the last point I want to end is on expertise and competence. Really, I felt the WHO was very incompetent throughout this, even in terms of just the basic health advisories. And I was wondering, what was so hard about this pandemic that they couldn't understand? Because we've had pandemics before, we had the Spanish flu, there's a lot of knowledge, and yet their guidance was really changing all the time and very variable, and didn't seem very competent at all. Thank you.
One last question, and then we can go back to the panel. Like, I will ask you for 4 or 5 minutes intervention.
Sure. Thank you very much, and to all the presenters for in-depth conversation. Especially around the continued legacy, colonial legacies on global health governance, including, and Omar spoke about this as well as others, including research. And I think, we already spoke about the COVID-19 pandemic being an eye-opener, not just in terms of vaccine inequities, but also just in terms of the lack of knowledge sharing across global divides. So I wonder, for instance, why will Germany or Norway, for instance, try to get experience about contact tracing from a neighboring European country, when the truth is Africa has a lot of knowledge in terms of contact tracing regard to some of the issues that we've seen in the continent. I have a question, a very broad and aspirational question around funding in terms of how do we reimagine global health funding. I mean, Omar alluded to that, especially in terms of the differences between an African institution, which will, for instance, spend over 60% of their funding on programming, while a Northern-based organization will spend, say, 30% of it, right? And so my question is, how will we reimagine funding, especially given that an institution in Norway, for instance, can access and will be given $150 million dollars or krona to do research when we know that an African institution wouldn't be able to absorb that. So how do we then reimagine the global health funding, especially considering the continued power dynamics and structures that both Pedro and Alicia alluded to earlier? Thank you.
Thank you. I don't know who wants to start.
Should I?
Yeah, go.
Well, I'll jump over the queue. Yeah, 3 minutes. Okay, I'll keep it as brief as possible. But so thank you for the fascinating questions, and I'll start with the one on, well, what kind of concrete ideas would there be for improving the current state of affairs? And as somebody mentioned, of course, the WHO has an image problem indeed, and it's the way in which it has issued advisory during the COVID-19 pandemic. Much of it was disregarded because either it was not politically feasible or it was downright, really incorrect. We can mention, for example, initial advisories on mask usage, where they said no masks only for the medical personnel, though not necessary for the population at large. And then less than 2 months later, they said we were wrong. They changed the advisory, but of course they had already tried to convince the global audience that one approach was the correct one. So I think that there's a common criticism, at least as far as I could tell, that this is a very big bureaucratic structure where all decisions take time, and once you make a decision, it takes a long time to really correct course when the decision really didn't reflect state-of-the-art medical knowledge. And on the other hand, I guess there's this reluctance to really, I don't know if it's reluctance or a lack of knowledge on how to deal with fast changing information like the one that we saw during the COVID-19 pandemic. Every month, not to mention that with the course of 2 years, we saw an explosion of research. So it was, of course, challenging to make sense of all of it. And of course, we would expect at least an organization like the WHO focusing on that to be able to somehow really reflect the state of the art more efficiently, but we see that it didn't. Well, this relates, how to deal with this? This relates me to the other question on what can be done concretely. So one way in which, at least in my own view, this is my own view, in which it can be dealt with is currently being discussed by means of reforming the financing schema of the WHO, right? Currently the WHO is mostly dependent on voluntary contributions, both by states and by private actors, referring to the role of private actors in global health governance. And this, of course, comes with many strings attached. I mean, actors will voluntarily contribute to the WHO to the extent that the WHO pays heed to these actors' own interests. And this results, of course, in the WHO itself and its member states not being really able to set the agenda on what will be done. But there is a proposal for a reform of this where governments are committing themselves to make funding less dependent on these pet projects and really more constant and without the need to really cater to the interests of a few donors. But of course, then the governments are currently wondering, well, shouldn't we expect as well some strings attached of our own, right? This is public money that they want to increase for the WHO. But one way would be to increase the means to hold the WHO accountable, for example, when they make mistakes, right? Blatant mistakes, and there are consequences for these mistakes. Imagine if these advisories are actually followed by national authorities, by governments, and this leads to a negative impact in the population. So shouldn't there be some sort of accountability for at least mistakes that could have been avoided? Of course, there needs to be an inquiry, but this has currently been discussed. This is a concrete way in which there can be a meaningful reform. I'll leave it at that in the interest of time, but just to address the other question on...
We have time.
Oh, no time.
To
Okay.
give.
So, Omar.
I think there was a question about racism, particularly when it came to vaccination during the pandemic. Well, yeah, and I remember one day I was in a faculty and I was trying to chat with a friend, and I told him that, you know, one of the things that we BSEPs promote here is equity. But what we are seeing now is inequity when it comes to these vaccinations. By then, our countries were struggling to have even a single dose of vaccine to our people. Here, people were already thinking of a booster dose. So it is something that has affected us a lot. But then again, we of course had some vaccines, but then again, the issue of knowledge. So the issue again was within the countries. There was a lot of misconceptions about the vaccines, you see. So this was a quite challenging issue to be addressed in many, many different ways. And we're still struggling because in our setting now, I mean, I was here and I was vaccinated here. And you see, I mean, you are told just to drop in there and you get vaccine. But in our settings, to be vaccinated, you need to kind of organize bonanzas and musics so that you entertain people. They come there, they're being vaccinated. So at the point where people were ready to support us with vaccines, we were not ready to be vaccinated. So in a way, we cannot say that there was this sort of racism, but ourselves, we had very limited knowledge. And there were a lot of skepticism on vaccines. So that's the issue. And well, there's another one about thinking of Reimagine funding to the universities. You know, here there are two different issues. And in most cases, there's this issue of transparency from the global north, but then a bitter pill to swallow, corruption. So you could have funding, but you think of channeling those funding to appropriate institutions and to be utilized for the intended purposes. So I think this is something that could be sorted out. And this is because of the nature of, I think we have a structure problems in us, at least in my own setting. I cannot speak of others. Because for instance, universities are under maybe certain ministries. So they are not fully autonomy. For instance, the university is back in our setting, they are under the Ministry of Education. So everything is being decided by the Ministry of Education and all that stuff. So I think these are the things that we need to sort out ourselves. And I think in the long term, this is something that we can work it out.
Thank you, Omar. Alicia, some reactions to the questions, to some of the questions?
Yeah, I'm gonna go super fast, and just picking up on what Omar was just saying. You know, I think we need to rethink what corruption means, right? That my government, that the German government is beholden to pharmaceutical monopolies is a kind of corruption that affects our lives and the lives of everybody on the planet. And now there's just been a legislation in the United States to reduce the prices of pharmaceutical companies here, and the pharmaceutical lobby is really threatening to put a target on the backs of anybody who voted for that legislation. So I think that that's a kind of corruption as well. Mistakes from the WHO. I think we have to discern between, this was an unknown virus that was completely evolving all the time. It is to be expected that there would be changing guidance. And I think we need to distinguish between that and the messaging that was not always aligned with countries, et cetera, and how we were to understand that. And the other kinds of mistakes, the one size fits all, so everybody could go to a house and isolate, as though everybody had Wi-Fi, as though everybody, as though everybody could do remote schooling, all of those questions, which I think the WHO did deplorably on. And third, the kind of structural dynamics of who are, under the IHR that Pedro is really the expert on. It's really about balancing measures with restrictions, undue restrictions on travel and trade, right? So why how are those balances made? Who are deciding those balances of keeping up trade, of keeping up economic measures? Because we live in a world hollowed out by neoliberalism for the last 40 years, where there aren't social protection mechanisms, where we can't afford to take time for people not to go to school, for people not to be productively engaged in the economy, and on and on. So that's on WHO. On the very provocative and important question Jackie asked, I'm not in a position to answer. In the conversations that I participated in, I think Jan Arne Rottingen, who was the sort of ambassador from Norway, has quite a different view of what the priorities in the TRIPS waiver were. I'm sure there'll be many interesting conversations there, and I wish I could be part of them. On Rachel's question about whether COVID made things worse or better, I would say COVID really revealed the entrenchment and the intersecting nature of neoliberalism, colonialism, patriarchy to some extent, the debacle that was COVAX, this emergency crisis-driven facility to put together vaccines instead of moving towards CTAP under the WHO, which would have allowed for know-how sharing and tech transfers more easily and been under the guidance of the WHO, has shown the world that we need to do something differently. So I'd say it's gotten much worse, but we need to do something differently. Having said that, the World Bank's financially intermediated fund is repeating the same mistakes of the past in terms of its governance. On racism, and I'm so sorry I can't see people's faces. On racism, I would echo something that Omar said initially, which is that, many of us, I live in a settler colony. So racism and white supremacy permeates, is imbricated in absolutely every institution in US society, really played out in this pandemic within the United States. It's not just about the colonialism on the global scale, but it's also what happens within countries. And I think we need to keep that in mind about thinking about decolonization. And finally, this very, very difficult question from somebody who I couldn't see, whose name I didn't get, about cautions for human rights or GPI. I also believe I've worked for many years trying to differentiate how funding is done. When I lived in Tanzania, the Danish government, Danida, that at the time Tanzania was its biggest recipient, we managed to get them to accept only the indicators the government was already collecting anyway, which is very different from what most global health donors do. So it was information that the government already felt was valuable. But GPI, this idea of global public investment, which has been incubated and co-created now for, I would say, 2 years, is going to be launched in a network at the General Assembly in September, is really about 3 things. All contribute. I mean, the G7 now has like 16% of the GDP of the world or something like that. It's really about expanding the number of countries who are making decisions about development and progress in the world. And all benefit according to their need. Obviously, poorer countries are going to benefit much more, and all have a say. So it's democratizing global governance. And I should say it's not just for health, although I'm focused on health, but it's also, think about all the problems we have in the world: social protection, digitization, climate mitigation, all of that. We need to change the incentive structures to think long-term, so another calamity doesn't have to destroy the world before we start to think anew, like about a Green New Deal, and invest long-term in things that are common shared needs. That also has the benefit of breaking down some of the nationalist silos, some of the security ideas. Well, I have a lot to say about human rights, but I'll stop.
Okay, thank you, Ali. And thank you, Ali, Omar, and Pedro, for this interesting. Probably we can continue that dinner, and thank you all.